Mr. Angel. My name is Victoria Angel. I'm at the United States University as an F&P student. For this assignment, I'm doing it on a cardiac assessment, and I do need to do a recording and upload it to YouTube for my for my instructor to grade it. Would you be okay with recording us?
Yes.
Okay, perfect. So at the start of a cardiac assessment, we would do blood pressures on both of the patient's arms while they're laying down and sitting up to check for any variances in the numbers, but we're not going to demonstrate that today. The first thing we are going to demonstrate is we're going to do a measurement of your carotid area. So we're going to go ahead and have you lay down. The bed needs to be at 30 to 45 degrees, which this one is pre-done about 30. When the patient is laying down, this is something that can only be done from the right-hand side of the bed. So we're going to ask the patient to go ahead and look towards the left. Let me grab my stuff here. And while the patient is looking towards the left, we just want to be able to visualize the carotid itself. And we're going to go ahead and have our ruler. And then when the patient is sitting in this position, we ask the patient to hold their breath for about 10 seconds. And we're just looking for the pulsation. When we find that, we want to place the card directly there and do a measurement of it. And in this case, we want it to be less than 3 centimeters, and his is only about 1. Okay, thank you, Mr. Angel, you can breathe. Okay, so that is checking for that aortic pulse there. Okay, then the next, you can go ahead and, so normally, again, the patient would be sitting here without their shirt on. While they're laying here, we would be just visualizing the abdomen, looking for any pulsations in the aorta, which is just above the umbilicus. We would even be looking for an apical type motion, palpation, visualization of that. Also looking at the patient just to see if there is any indicators of discolorations or other abnormalities. In this situation, we would not see that, but we would go ahead and have the patient sit up at this point. Go ahead and turn around. And then we're going to look at the carotid arteries. We like to visualize everything first, so we did do that while he was laying down. When we do carotids, we like to auscultate and listen to them one at a time, and then we also like to feel them. So I'm going to start with auscultation. So we're going to go ahead and feel just a little bit here. And while I'm listening for the sound of a bruit. Hopefully we don't hear one, because that's what we don't want to hear. Okay, to be negative. So we would listen on the other side. And he's negative. So then with the carotid arteries, you never want to feel them both at the same time, but we would just feel with 2 fingers over here. And we're feeling for what's called a thrill. We don't want to feel that, and so that's a good thing. And then we would change and feel the other side. While I have the patient sitting up, I like to examine their fingers for any signs of clubbing, cyanosis, checking capillary refill of each finger. We do check them all to make sure they are less than 3 seconds. And as I'm completing that, I'm also looking for any signs of slivering on the nails, tar type coloration, which would be an indicator of a smoker, those types of, and then like I said, clubbing of the fingers as well. Okay, then we are going to auscultate the heart. We do listen to the heart with both the diaphragm and the bell, so it's both sides. I'm going to go ahead and demonstrate at this time. So we start up in the second intercostal space of the right sternal border, and that is your apical pulse. We're going to start with our diaphragm. And we just listen, and we're listening for what's called an S1, S2 splitting sound of the heart. Okay, from there we would move over to the right second intercostal space, and that's your pulmonic area of the heart, and again we're listening for those sounds. From there we move down and we're listening to what's called Erb's point, and it's in the third intercostal space of this left side. And from there we move down to the fourth intercostal space on that left sternal border. And from there we're listening to the tricuspid. And then the last sound we listen to on the heart is the mitral valve, which is a mid-clavicular of the fifth sternal border. Again, a normal S1, S2 sound. I'm going to go ahead and listen now with the bell of my stethoscope. So again, apical, second intercostal space. Pulmonic, second intercostal space of the left sternal border. Erb's point, which is your third intercostal space on the left side. Tricuspid, which is your fourth intercostal space. And mitral, which is midclavicular, fifth intercostal space, and known as the maximum point of intensity when listening to the heart. Okay. Also with the patient, we would make sure it's, patient would normally be laying down for this, so I'm going to go ahead and lay down. We would be, again, without a shirt you could visualize, but it would be for the aorta. So we're going to make sure it is measuring less than 3 centimeters. It is in the deep, you have to feel it deep up in the epigastric area, so it does take quite a bit of pressure. If you see something visualized, obviously don't palpate deep, but you would be able to kind of feel the borders and the edges of it. It should measure less than 3 centimeters. We also, when a patient is laying in this position, it's a good time to be able to feel the femoral arteries, which are in the groin area, and even be able to auscultate those sounds when the patient is laying down. It's much easier to hear. Okay, and then we go ahead and have the patient sit up at this point. We're going to go ahead and palpate, and we want to be able to feel for the brachial pulse. We would feel on both sides of the body because we want to make sure that everything is symmetrical. For brachial, we would also feel the radial pulse. Again, we would be repeating it on both sides. All right, then next, again, because we already did the femoral, we would move down to the popliteal. It's, for the sake of the video, we're going to raise up, but normally it would be dangling and it's easier to feel. But in this situation, it's deep behind that kneecap. As I would be palpating the patient's legs to be able to feel for that pulse, I would be visualizing for any discoloration, signs of cyanosis. Once that's the popliteal is palpated, again, left and right, we would move down to the tibial, be able to feel that. We would also be examining the toes for a capillary refill. Again, all 10 toes, we would palpate to make sure that the cap refill is less than 3 seconds. The last pulse that we're going to feel for is the dorsal pedialis, which is right towards the top of the foot here, kind of in line with the big toe. But again, we would be making sure that there's no signs of clubbing or cyanosis on the toes. All right, Mr. Angel, I think that completes our assessment of cardiac. Thank you.
Thank you.